Good afternoon, and thank you for joining today's Future of Healthcare panel discussion. Today's discussion is co-sponsored by Cabarrus College of Health Sciences and Carolinas College of Health Sciences. Both colleges offer a variety of health science programs, including degrees and certificates that can help Atrium Health teammates and other students advance their careers or step into new roles. Many of our programs even offer loan forgiveness for teammates. So for more information, visit cabarruscollege.edu or carolinascollege.edu. My name is Dr. Meg Patchett, and I serve as the provost of Cabarrus College of Health Sciences. I'm joined today by Dr. Lori Bequette, provost of Carolinas College of Health Sciences, and today we will be serving as moderators. We are exceedingly fortunate to have a distinguished group of panelists with us today. Our format, as I mentioned, will be a panel discussion. Dr. Bequette and I will take turns posing questions to our panelists, and our panelists will respond in turn. We have prepared questions about the future of healthcare in which everyone will have an interest. In addition, we will also share some pre-recorded questions from students and faculty. With time permitting, we will also field questions that are posed in the chat feature of Microsoft Teams, so feel free to enter your questions into the chat. And finally, please note this panel discussion is being recorded so it can be viewed at a later time.
So I'd like to start by introducing our first panelist, Mr. Doug Edgeton. Mr. Edgeton is an executive leader with a career that is focused on healthcare within major academic medical centers, research park development, and business administration, including an emphasis on community service. Throughout his career, Mr. Edgeton has managed both human resources and facilities, helping them work in concert to create the right ecosystem for organizational growth. This approach has led to more efficient organizations, faster technology transfer, and better patient care. Mr. Edgeton joined North Carolina Biotech in 2012 as Senior Vice President for Financial Planning and Development and conducted a top-to-bottom examination of programs, staffing, and finances. The examination resulted in an additional $1 million in state appropriations. He then led the development and implementation of a new organizational strategy when he became President and CEO in 2014. At the Biotech Center, Mr. Edgeton has adopted an approach of targeting state investments and staff expertise to help North Carolina's life science companies grow, create jobs, and bring life-changing technologies to market. Prior to serving at North Carolina Biotech, Mr. Edgeton held senior executive, administrative, and financial roles at the Wake Forest University Medical School and Health System. Strategic planning and business management processes he employed laid the groundwork for the Piedmont Triad Research Park, now the Wake Forest Innovation Corridor, and the integration of Wake Forest Medical School with North Carolina Baptist Hospital. He took on greater responsibilities and was part of the team that helped establish the Wake Forest Institute of Regenerative Medicine. Prior to joining Wake Forest, Edgeton served in central administration and hospital administration roles for the University of Alabama at Birmingham. He holds a bachelor's degree from the University of Alabama in Tuscaloosa, and MPH and MBA degrees from the University of Alabama at Birmingham. He has extensive involvement in professional, community, and civic organizations, and currently resides in Raleigh with his wife, and they have 2 adult children.
I have the pleasure of introducing Val Kratzman. Mr. Kratzman is an international business strategist with a systems focus and operational solution sets. He has over 35 years experience in the international marketplace, working with startups through Fortune 100 companies. He has worked on both the client and agency sides of the business equation, having established U.S. operations for foreign companies, launched new consumer, medical, and scientific products, and he has been active in mergers and acquisitions and IP transactions. He currently serves as Director of Healthcare for the Americas for Business Finland, which is Finland's innovation, investment, trade, funding, and tourism agency. In this role, he works with startups and subject matter experts to clinically validate new healthcare technologies and globally grow those companies. His work with Finland started in 1994 when he was appointed Trade Commissioner to the United States. Here he served as head of the Finland Trade Center in Washington, D.C., sitting on the ambassador's commercial staff. And he is the architect of the Nordic Amplify Accelerated Market Entry Program, designed for Nordic digital health companies entering the United States. Prior to Business Finland, Mr. Kratzman led the KPMG team that created the international management consulting company Bearing Point. He was vice president and global director of economic development for Burson Marsteller, acting as a foreign direct investment advisor to several prime ministers. And he began his commercial career in healthcare, with the Australian government assessing new medical technologies and therapies. If you're wondering how he got to this illustrious career, his educational background started at Penn State University. He earned a bachelor's in social psychology and biochemistry. He completed the advanced management program at the Wharton Business School, and he further completed graduate studies in healthcare administration at George Washington University. A couple of fun facts. He's a mentor and judge at the Yale Center for Biomedical Innovation and Technology's Healthcare Hackathon, so look that up. He is a published author and guest lecturer, and he currently resides in Fairfield, Connecticut, with his wife, who is an environmental educator.
Thank you.
And I have the privilege of introducing our third and final panelist, Dr. Rasu Shrestha. Dr. Shrestha is a healthcare executive with a wealth of experience in national expertise in healthcare innovation, analytics, and patient-centered care design. In his career, Dr. Shrestha has helped organizations push the needle in the pursuit of a unique blend of healthcare intelligence, technological expertise, and entrepreneurial drive to develop inventive and commercially successful solutions and address complex healthcare challenges. Since February 2019, Dr. Shrestha has served as the Executive Vice President and Chief Strategy and Transformation Officer for Atrium Health, where he is responsible for Atrium Health's enterprise strategy, including planning and tactical direction for the organization's current strategic roadmap and beyond. In addition, he spearheads a renewed focus on innovation, launching new healthcare inventions, discoveries, and ideas to benefit the patients and communities that Atrium Health serves. He also provides executive leadership for corporate communications and marketing, as well as enterprise analytics. Prior to coming to Atrium Health, Dr. Shrestha served as Chief Innovation Officer for the University of Pittsburgh Medical Center, where he was responsible for driving their innovation strategy, serving as a catalyst in transforming the payer-provider organization into a more patient-focused and economically sustainable system. He also served as Executive Vice President of UPMC Enterprises. Impressively, if that's not impressive enough, Dr. Shrestha was the youngest student in his college in Malaysia and received his medical degree from CCS University in India. He then completed his training in radiology and his fellowship in informatics at the University of London. He also earned an MBA at USC's Marshall School of Business. Now, he is certainly a respected thought leader and visionary in the field of healthcare information technology and received numerous recognition and awards, including being recognized as Executive of the Year by Healthcare Dive, and was acknowledged as one of the top 20 health IT leaders driving change, and as a top healthcare innovator by Information Week. He serves on a number of professional boards and organizations, including the Board of Directors with the Healthcare Information and Management Systems Society, the Society for Imaging Informatics and Medicine, as well as the Board of the Blumenthal Performing Arts here in Charlotte. Thank you. So I think with that, we can get started with our questions for our panel. And so we've got all three of our gentlemen ready to go. The first question is going to be focused on broad trends. So to start us off today, can you please help us identify some broad trends in the future of healthcare that will be caused by technological advances? Mr. Kratzman, if you'd like to get us started. I believe you're muted.
Oh, thank you. I think from the technology perspective, technology is probably one of the three legs of the future of health, and followed then by mathematics, which allows us to have AI and machine learning, and then by geography. And by geography, I mean healthcare being able to go that last distance where hospital at home or health anywhere will become possible. But in broad trends, I think what we're going to see is we're going to see an increase in the number of handheld devices that can be used anywhere. I'm working on a technology right now, which is basically a tricorder that we used to see in Star Trek, where we can actually measure inflammation, and understanding where the inflammation is coming from, we can then determine what is the cause. So I think handheld devices, genomics, mathematics are really the future that we'll be paying attention to.
Yeah, those are great points, Val. If I could add to that, I love the notion of the tricorder, right? It's something that we've been waiting for a while, and you know, let's hurry up and get it done. You know, in terms of the broad trends in the future of healthcare technology, in addition to everything that Val just mentioned, I think there's a lot of advancements in specific areas such as robotics, for example, simulations. Really excited about the future of simulations, and I'm talking to, you know, an audience here that's really focused on education. And when I think about virtual reality, augmented reality, mixed reality, all really now coming of age and aiding in the advancement of education, specifically in the healthcare realm. Very excited about that too. The two other things I'll quickly mention is around digital health. It's really interesting, even as we've been living through the pandemic in the last year plus, the pace of investment in digital health has really dramatically actually increased, not decreased, but increased. And last year alone, Rock Health said that it was $14.1 billion in investment in digital health. And a report came out this week that basically outlined that just in the first quarter of this year, there was $6.7 billion of investment in the first quarter alone of this year, the majority of which comes from rounds worth more than $100 million. And it's really startling to think about that. So I think that's a big trend, the embrace of digital health. You know, companies like Doctor on Demand that merged with Grand Rounds. There are big payer organizations like Cigna's health services subsidiary called Evernorth that scooped up MD Live, a company that does a lot of the telemedicine virtual visits that we saw bump up in the through the pandemic. United Health's Optum group acquired Change Healthcare. So lots and lots of things that are really accelerating in the space of digital health. And that's the last point, is that pace of acceleration in the adoption of these technologies is dramatically increasing as well.
Yes, I also think, to continue with that, the pandemic showed us that healthcare and the economy are inseparable.
Yeah.
And I also think the other point is that the pandemic proved to healthcare that we can turn on a dime. It's quite possible. 7% of doctor visits have gone virtual because of the pandemic. And that's really making up for that $1.2 billion a month loss that we saw in the beginning of the pandemic.
You know, that's a great segue into one of the questions I wanted to ask, and that is, you know, some of the healthcare experts are saying that the pandemic has accelerated the pace of healthcare technology by as much as 5 to 10 years in just 1 year's worth of time, especially when it comes to telemedicine, virtual care. So the question becomes, is virtual medicine here to stay? And I'd really be interested in hearing, Mr. Kratzman, if you could share with us about activities that have been occurring in Finland.
To answer your question, yes, it's here to stay. In Finland, Helsinki University Hospital, where I do a lot of my work, is the largest academic medical center in Europe. And they've done a lot of very, very interesting things. One technology that did not come out of Helsinki University Hospital, but was quickly adopted, is a company called Video Visit. And Video Visit really has moved care into the homes. And they have three models. They have home care, where you can talk to your physician. You have live, where you can actually have an examination virtually. And the third one is called remote, which is where you can actually be diagnosed, and patients will be given basically a briefcase with all the necessary tools. And the doctors can make the diagnosis virtually. I think it's fascinating. There's another company called Medified that we've just started working with, and they've moved mental health to the mobile phone, so that there's actually connectivity between patient and doctor, or tracking what the patient's modality, what their moods are, how they're feeling in between visits. That information is sent to the doctor, goes to the cloud, and it is analyzed. And so when the patient goes back to see his or her physician, there's really not a beat missed, and they can continue. And then the third area I think that I wanted to talk about is Clever Health Network, which is a co-development group out of Helsinki University Hospital that has moved kidney dialysis into the home space. We actually have more patients in Finland using kidney dialysis at home than by going to centers. So it's giving them a new sense of life. So yes, virtual care is here to stay, and it will grow.
Fascinating information. Dr. Shrestha, would you agree with what Mr. Kratzman is saying, that it's here to stay? And can you tell us a little bit about Atrium Health and any intentions to expand virtual care practices within Atrium?
Absolutely. It's definitely here to stay. As a radiologist, our field was one of the first to really embrace tele and teleradiology. And it's amazing how in the last year, as we've been living through the pandemic, and if you remember, it seems like a while ago now, but initially in March, when the pandemic hit us, we shut down our hospitals and turned on in a dime, our AI-powered chatbots, and really upped the game in terms of the virtual video visits and the virtual elements that we're talking about today. Now, these are not services and capabilities that we didn't have. We've had them for a while. In fact, I call virtual care or telemedicine the overnight success story that was 30 years in the making, because we've been working on this for such a long time, and we've had these capabilities in place. More recently at Atrium Health, in addition to all of the different capabilities that were just mentioned around asynchronous and synchronous and video visits and such, we just launched what we're calling our Atrium Health Virtual Edge, which is a platform that enables a much more cohesive approach to virtual care across the board, and delivers a consumer-oriented set of care options that really attract and retain patients and consumers, and then optimize convenient access to care, delivering the outstanding best-in-class value to patients and consumers. And I think that level of focus on experience is the other thing that's really going to take the conversation further around the embrace of virtual care. So it's here to stay, and whether it's around neurology or critical care or stroke medicine, or managing patients at home, and really focusing on well-being versus managing sickness, virtual care is definitely here to stay.
I fully agree that moving to this space, we're going to start to see a new period where wellness will become a real focus and a reality. And then for the CFOs of the health systems, some quick numbers: virtual care is 85% more cost effective than a physician or a physician home visit. Physicians actually can increase their caseload by 10 times more patients on a weekly basis, on a daily basis per shift. 400 million euro, I'm sorry, I have European numbers. 400 million euro savings for healthcare providers within a group practice and our combined closed health system. So it really has proven itself.
Wonderful, thank you.
So it's interesting to hear about this potential really broad impact of virtual care, and obviously we're going to see some sustainability there. One necessity potentially for virtual care, especially when we're talking about these hospital at home concepts for patients with chronic conditions, is the utility of digital monitoring devices. So in using or learning to have patients use those devices, what types of skills and abilities will our healthcare professionals of the future need to possess in order to utilize these tools to help patients? Mr. Edgeton, I'd like to hear your thoughts on this.
Certainly, thank you. Thank you for letting me be a part of the conversation today. I think that the future of the devices and the things that are going to connect people are things like was said. They're here to stay because of COVID, but it's been a long time in the making. You know, we've used Holter monitors and things like that to monitor people's cardiac rhythms for 20 or 30 years now. And I think those devices and wearables that people are starting to carry with them as they get more accurate and can share data accurately will be much more effective for clinicians. There is probably going to take a little bit of time for, I think what generally happens in healthcare is the people who are residents now are learning things that will become standards of care in a few years. And as other healthcare providers retire, the new tools, new techniques will come online. So I do think that we're going to have better ability to get away from white coat syndrome, where people really have different reactions when they're in the physician's office, and you'll get a more regulated look at their regular life. So, and I think things like diabetes and other chronic health conditions will be managed much more effectively through regular routine monitoring, so you know when you get glucose spikes and things of that nature.
And Dr. Shrestha, anything to add in terms of different kinds of devices we might be thinking of?
Yeah, absolutely. Really good points there in terms of those devices. You know, one of the things I wanted to point out as we're talking about digital devices is I think the care models are changing in front of our very eyes today. You know, our patients, our consumers, our communities, they're more online and engaged and curious than ever before, you know, and these devices that we're talking about, whether it's the Bluetooth enabled glucometers, whether it's, you know, everyone's got, you know, a Fitbit type of a device on their wrist that's measuring how they're sleeping, how much they're walking, and various other parameters. In my new Fitbit, I have the ability to get an EKG, you know, just on my wrist. It's just absolutely amazing. And this change that we're seeing right now is one that is, I think, pretty important, right? So up to now, healthcare has largely been about episodic care, right? You come in when you're sick, or you come in for your annual physical, or your you know, mammogram, or your colonoscopy, or a visit, and I think it's moving to more of a 24/7, always on, ubiquitous care model, and in fact, it's moving towards more of a health model, right? And the focus here isn't just on getting better from an illness or surviving a catastrophic healthcare event, but it's really on thriving. So moving from surviving to thriving, and that's where I think digital devices and this notion of the IoMT, the Internet of Medical Things, right, where various devices and sensors are really connected to, you know, think about an air traffic control model, where hospitals essentially now are converted to air traffic control centers for the communities that they're monitoring, in terms of not just getting better from a congestive heart failure, you know, a patient who gets discharged, or a patient who maybe gets discharged from a knee surgery and is going through various types of therapies, maybe at home or in the hospital itself, but also where we're monitoring patients throughout their wellness journey, right? And focusing on in the specifics of, you know, their wants and needs and desires in the categories of the patients that we're actually monitoring. So really exciting to be watching today and enabling the very transformation of how it is that we're caring for our populations.
I think Rasu raised a very important point of that we're moving towards wellness, but I think more importantly, we're moving towards accountable patients, where people are becoming more accountable for themselves because we've allowed it to happen, and because the professional community wants to see that information. So I think some of the silos and some of the barriers that have historically existed in medicine are being knocked down for the good.
You know, it's interesting because as you talk about these, the proliferation of these stationary wearable digital devices, they're going to be creating a lot of data. And I think this creates questions about the interoperability of devices, patient privacy and other types of concerns. So I'd be curious, Mr. Kratzman, the Nordic countries of Finland, Iceland, and Sweden are ahead of the United States in the utility of a more standardized and secure use of electronic medical records. Can you tell us about maybe what we might expect in terms of where the U.S. may be headed?
Yeah, I think the question of data we'll put off to the side because I don't think anyone has an answer or really knows how to attack it. There's wellness data, there's medical data, there's fitness data. So there's many different types of data. Finland made a decision in 2011 to reform healthcare. And a lot of it came from the fact that they were sitting on 100 years of data. They have biobank data from the 1920s, and they have the first longitudinal record, registry from 1953, which was the cancer registry, which really is a global gold standard. So there's 19 different registries in Finland today. So they made the decision that the data had to be protected, but more importantly, the citizens' privacies had to be protected. They passed over 144 laws in 2 years to make sure that the data was used, that it was safe, that it was being used correctly. And then they sat there and they got stalled for 2 years on the concept of secondary use of data because they wanted the European Union to pass the GDPR laws, which are the general privacy laws. So they watched and waited, and once the GDPR laws were passed, they then passed the secondary use of data. So we have 100 years of data, it's fully digitized, and it's 100% accessible for anyone who wants to come and use it for research purposes and for the betterment of society and health. The Helsinki University Hospital made a decision that they wanted to have an Epic installation. My comment to them was that for that kind of money, you can probably build it yourself and then sell it to the East. But the reality is they did install an Epic system, but there were a lot of compromises. Finland had its own EMR called Kanta, and it included everything from life to death, birth to death, social care, social determinants of health, prescription records, employment records, lifestyle records. I tend to say you can actually have so much data, you can actually drill down to see how many speeding tickets somebody has. But they made the decision to take this information and layer it in on top of the clinical information on a traditional EHR or EMR. So Helsinki University Hospital has the clinical data, it has social care data, it has social determinants of health, has longitudinal data, has biobank data, it has genomic data. In fact, Finland is sequencing all newborns right now. It then has the genomic data, and then more importantly, it has patient-reported outcomes. And this goes back to what Rasu was saying, that digital really hasn't allowed the patient to become part of the care process. And in Finland, they want to see the patient reporting that information. So when a patient walks into a hospital, their record is on a chip like you have on your credit card. They walk in and their record automatically pops up at the reception when they're admitted, and then they're directed to where they want to go. So it's really, they've taken a lot of time and a lot of care to protect the citizens, as they say, but also to move towards more efficient and more effective healthcare. And Finland for 3 years in a row now has had the most efficient healthcare in the world.
With all those efforts, I have to believe that there were a lot of new job opportunities that were created. And so I'm wondering, Dr. Shrestha, what workforce impact are employers such as Atrium Health currently seeing relative to healthcare information technology positions? Is there an increasing need, just as there likely was in the Nordic countries?
Absolutely. So what's really interesting is in the United States, we're chugging along as it relates to embracing electronic medical records, electronic health records. Part of it was really the federal incentives, the meaningful use dollars that were out there that really incentivized and then penalized physician practices and hospitals who weren't on the electronic health records yet. So that really caused for a dramatic bump up in the embrace of electronic medical records. Now, is it as ideal or optimal as it needs to be? We are far from it. But having said that, absolutely, there's been an increasing need for really trained individuals to come in and help with the deployment of a lot of these solutions. And we've seen also a dramatic shift in the way that these requirements, the jobs are actually changing. So I'll give you a radiology example. When we started deploying voice recognition systems for our dictation that we do for our reports, initially, prior to that, we had a lot of transcriptionists who were, typing out the reports. And when we had the voice recognition systems tied to our PACS systems and the radiology information systems, that reports would go out to the electronic medical record systems, a lot of the transcriptionists essentially then became either PACS administrators or became IT professionals who would help with the deployment of a lot of the solutions, or coding specialists at the back end. I'll give you a more current example as well. So even through the pandemic, as we deployed our Atrium Health Hospital at Home program, and it's not just the physicians who are essentially involved in the care of our patients, it's also registered nurses and paramedics and others who are really, really involved in leveraging the data that we're collecting in our electronic health record systems. And whether it's models where we're actually leveraging patients' homes as the next iterations of the hospitals for patients that don't need to be admitted in the busy ICU, especially as we're living through a pandemic, or it's more the traditional deployment of electronic health record systems. These job descriptions continue to change, and the one thing that I'll push for is, for us to continue to think creatively in terms of where is technology really going. I think maybe we'll get into this conversation a little later, but the embrace of artificial intelligence, for example, right? That's something that we really need to focus in on, and oftentimes, when we think about medical education or education for healthcare information technology teammates, technologies or capabilities like AI oftentimes isn't front and center, but I think it absolutely needs to be. So lots of opportunities there for sure.
Wonderful. Mr. Edgeton, we'd love to bring you into the conversation as we're talking about electronic health records. What are some of the applications or concerns you're seeing at the state level relative to electronic health records?
So I think that one of the things you see across the state, of course, the pandemic has really kind of cracked the door open a little bit further so that DHHS, public health, and hospitals are now much more connected and communicating information somewhat in a reactive mode to what was happening. So you're not really getting to the power of the pure population health yet. But I think that because the pathways are now open, you'll start to see more of that kind of activity in much more, I guess, prospective ways instead of a reactive way. So I think what we're seeing too across the state is you have people who are very interested in putting their medical information out there, and you have a lot of people who are concerned about the security of that information. Until we do some things, maybe like Val was talking about, we may not be able to get people to share their data as readily. So, and we're still systemed, off by different healthcare delivery systems. So there's not a cross-functional, cross-talking way of using all of the power of this data. So what I tell people is we have a lot of data. We may not have as much useful information that we could get out of that data if it were more connected. So coders will have a future. Coders will have a future here.
Well, so I think that those comments provide a perfect segue to the next question, because we talked a lot about the collection of the data, and I think talking about how then do we convert it to more useful information. So with individuals potentially having a more complete health record, all of the patient data being captured and transmitted will allow for greater use of artificial intelligence, both for helping doctors diagnose individual patients and for population health experts to use that big data to identify evolving threats to public health. So Dr. Shrestha, would you like to speak a little bit about how we can use some of this artificial intelligence in diagnostics?
Absolutely. What's really interesting is that while we're swimming in the sea of data that we're talking about, I believe that we're data rich and information poor, right? And we as human beings can only process certain amounts of streams of data that are hitting us, and oftentimes we're more detectives than we are clinicians, because we're always trying to piece various bits of information from various information systems that are open in front of us, and we're talking also about other types of data, including devices and sensors and social determinants of healthcare data and such as well. So the promise of AI really is to make sense of all of that data and bring us actionable insights that are relevant to us in the entirety of that care journey. So as a physician, I can tell you that the opportunity for AI to really streamline my workflow, and really the promise, I believe, is to humanize healthcare. And as much as we talk about artificial intelligence, what I'd really like to do is to have AI, artificial intelligence, remove the artificialness that technology embedded into the care process in the first place. Technology oftentimes, and a lot of it because of blotched EMR deployments, has become a barrier to better care. There's a computer screen between me and the patient, and that's not how we're doing things in a lot of cases here at Atrium Health. We're really directly connecting with our patients, but that's the general reality of how EMRs are deployed. And I think artificial intelligence could really help with freeing up my time by getting me the relevant information that I need at the right time. And so AI, if done right, will really be augmented intelligence. It's augmenting the intelligence that that needs to happen in terms of the conversation that I have with my patient, or with their loved ones, or with the care team. And that, I think, is the true promise of AI.
So, Mr. Kratzman, perhaps you could speak a little bit more about the broader implications as it relates to population health and I'll say the augmented intelligence.
No, I agree. It is augmented intelligence, and I haven't heard that expression, data-rich information poor, but I fully agree with it. We were distracted for so many years with electronic medical records. We're getting distracted with data, not understanding what data is. I think data from the population health perspective, if you start looking at it from a broad stroke, where we can layer in information, social determinants, geographic data, it allows us to really move away from disease management, which we know really never succeeded, and focus on population management. And if we can focus on population management, we can better understand the diseases, and therefore we then circle back into using the data to taking a look at what the genomics are telling us, what the other information we have. So I think there's an entire new industry out there in terms of healthcare informaticists, but probably more healthcare investigators who can really go into that data and figure it out. We've done it for sociology for years. I don't see why we're not doing it for medicine. But I think it will allow us to move to a better population management. And then if you work that backwards, it means that hospitals can make decisions on how they want to treat and where they want to treat their patients. I think Kaiser's done a very good job in taking healthcare to the people, whether it's a library or a city park. I don't think that's too far-fetched, and I think it's very, very possible. I've done a lot of work with Dr. Steve Landers, who used to be at Cleveland Clinic. He now runs VNA of Health Group of New Jersey, and he basically believes in home care. And he's got over 700 people doing home care for him, and they're doing it very, very differently than what we would normally think is home care. But that's also population health. So they're managing a very specific population, homebound either because of surgical procedures or because of other economic or health issues. I think it allows us to look at things very, very differently.
And you mentioned the importance of genomics and how that's going to become more influential over time. As we look at genomics and precision medicine, there are opportunities for patients now to have their DNA analyzed. The healthcare providers can identify prescription medicines and food and vitamins and even the best exercise routines for patients based on just simply their genetic code, which is fascinating. So what I'm curious about, Mr. Edgeton, what are some of the applications of genomics you're seeing in your work with the North Carolina Biotechnology Center?
So I think the most prevalent thing you'll see is in pharmacogenomics and treatments for cancer therapies. You're seeing a lot of things in that space that where people are able to track targeted therapies and see how they respond to those. You know, there are, of course, the over-the-counter things you can get, like 23andMe. I'm in a couple of these genomic databases, and personally have learned a few things to tell my doctor not to ever give me. But on the one hand, I show my doctor the stuff, and he says, "Wait, I can't take all that because I don't know what to do with it." So that's another challenge for us. How do you integrate these personal pieces of information? A lot about your family history, a lot about you know, things that you probably know some story of somebody in your family who had something, but how does that affect you? Do you carry those traits? And what do you do with your doctor to align your health care personally? Across the state right now, I still see us in kind of an early stage. We've been working on a project called CHAMPS to get some local companies to provide genetic testing for their employees, and then try to build up a database of regional activity that would help us better understand what goes on in different regions. So there's a couple of things going, but we still have a lot of work to do in this space. You know, the genome was sequenced a long 25 years ago.
Yep.
We thought a lot was going to happen in just a few years, and it's taken us a long time to understand what that means. But we're starting to see more and more companies popping up that are specialized in a particular trait or gene. So.
And I'd be curious, Mr. Kratzman, if you could add to that what you're seeing internationally.
Yes, Finland started talking about genomics many years, probably 12 years ago, but 7 years ago we funded a program. I should say we at Business Finland, my organization, because we're basically the technology bank. We funded a project called FinGen, and it was a joint venture between the Finnish Institute of Molecular Medicine and the Broad Institute in Cambridge, Massachusetts. And it's basically was saying we want to sequence 10% of the Finnish population, so 500,000 people over 3 years, and understand what we have with that data. And that program has grown. We're in phase 2 of it right now, and we have 13 international pharmaceutical companies as our strategic partners. And the pharmaceutical companies have agreed to use the data, but not only the genomic data, but all the social determinant of health and all the longitudinal data in Finland. And they're using it for drug discovery, drug development. In Helsinki University Hospital, the really objective is to move towards bedside genomics by 2025. And by that, what we mean is when a patient comes in, we have the data. We hopefully will have some kind of sequence on file from them. If not, we can do the sequence quickly, and then we can really determine what we have to do and how to treat that patient properly. So it's kind of taking the right drug for the right dose at the right patient at the right time to an entirely new level. Helsinki University Hospital has also instituted ICANN, which is the Digital Data Precision Medicine Cancer Center. And they're applying all the data specifically to cancer to understand how do we identify it early, how can we eventually treat it, and more importantly, can we prevent it? And by looking at the spikes that we're getting in the data, we're learning an awful lot about the Finnish population. We're seeing single spikes on a big sequence for a single genome, and then working that backwards, we're allowed to understand why that's happening. So in Finland, we do have a homogeneous population, but because we do have a homogeneous population, we also know where the genomic dropouts are. So those spikes are even that much more significant on a global basis.
Dr. Shrestha, as you listen to all of this that Mr. Edgeton and Mr. Kratzman have shared, what are your reactions?
Yeah, no, it's a fascinating conversation, and I was up in Winston-Salem on Monday, and I spent the entire day there talking to a number of the researchers and professors and and folks that are really involved in pushing a number of these fronts forwards, including in precision medicine and in genomics. I think the holy grail in healthcare has long been personalized medicine, or what is now called precision medicine. But getting to that level of precision we wanted wasn't really possible until now. Yeah. I think what changed all of this was our ability to sequence the human genome. And so it was almost 25 years ago, I think April of 2003 was when the Human Genome Project announced that it had sequenced around 20,000 genes of those that make up the blueprint of our bodies. And yeah, think about that, right? 25 years, and so much progress has been made since then. And today, these fast, large-scale, low-cost, and that's really important, the low-cost DNA sequencing has really propelled genomics into the mainstream medicine, driving a revolutionary shift towards precision medicine. And I think healthcare, as a result of that, is really moving towards prevention rather than cure. And we're talking not just about diseases and being really precise in terms of the dosing and in terms of how we manage these diseases, but we're also talking about pre-disease as a result of what we know around genomics. And with DNA sequencing heading below the $100 mark, I think by 2025, as many as 2 billion genomes could have been sequenced, and that's really remarkable. And so yes, there are challenges in terms of how do we integrate this more actionably, if that's a word, into our specific workflows. But I see the promise of genomics, especially at a cost point of below $100 mark for DNA sequencing, where it's and that's where it's heading towards right now, as being a big accelerant in the embrace of genomics in the right way and moving towards the promise that we're talking about here.
Thank you.
And then on the data side, almost every 10 years we've seen a transformation based on the amount of data and a new focus. And so we've gone from security to today, as Rasu said, the Internet of Medical Things, and now I'm working on something, the Internet of Medical Implanted Things. Mm-hmm. But in genomics, we're actually starting to go into proteomics now, where we're looking at the proteins, and Somologics out in Colorado is doing phenomenal work in this space. And there's so much more knowledge we can gain from understanding the proteins too.
So I think at this point, Dr. Patchett are going to take a break from asking questions, and we're going to hand it over to, at this point, a Carolinas College student that has a question for our panelists.
Hello, my name is Tara Igbenall, and I am a nursing student at Carolinas College of Health Sciences. If you were an undergraduate student today, what would be your area of focus, and what experiences would you be focused on acquiring? Thank you.
So I think we have time. I think each of you have a very different background, so you may have a very different answer to that question. Mr. Edgeton, would you like to start what you think about that?
Certainly. Thank you. Good question. I think that everybody finds their own path in life, and they find what's interesting to them. I started off with the idea that I wanted to be a very good generalist, and I've gradually specialized over time, starting off broad and narrowing my scope. So I started off as a hospital administrator and then moved into research administration, and then patents, and then technology-based economic development. And so that's a great path. And I tell people all the time, if you're really career bound, there are a number of opportunities in life sciences companies. You don't have to be a PhD to actually have a job in that space. In fact, they are that's like 4% of their workforce. So there's a lot of opportunity for people with a variety of backgrounds in life science companies, and some of these larger companies provide really phenomenal careers. So a lot depends on your interest as a person.
Dr. Shrestha?
Yeah, thank you. Fascinating question, and I think the student's name was Laurie Beckett, and Laurie is asking the right question at the right time. When I put her question in the context of the excitement that we're creating here at Atrium Health when we announced that with Wake Forest Baptist Health now being part of the family, we're going to essentially open up the first, four-year medical school here in the city of Charlotte, the second campus of the Wake Forest School of Medicine. And you think about, all right, my undergraduate days, and Laurie was asking, what would have been my focus areas, if I was, making those considerations again today. And when I think back to my journey and parlay that against sort of the excitement of what's going on today, I'd say three things. One is I'd really focus more intentionally on design thinking. And design thinking is a discipline, right? It's a methodology of really looking at pain points and capabilities and solutions, and really making sure that you're able to have a fail-fast methodology, an iterative methodology to getting to the right solutions, and then the implementation elements as well. So the design thinking philosophies. Second is AI. We talked about artificial intelligence or augmented intelligence earlier, but I think it's really important for students today to really make themselves more aware of what's going on in the world of AI. Third, I'd say is because perhaps of how AI is coming into the foray around healthcare, I'd focus in on the human elements of what distinguishes us human beings from those machines, right? They say run for the hills, the machines are coming, but focus in on things like communications, empathy, leadership. And there, I could go on, but there are specific human elements that I think, are really, really important for us to really nail it and make sure that we're able to be on top of, because again, AI is going to augment the elements of how we're providing health and care to our patients and to our communities, but focusing in on those human elements, I think is going to be really important.
Mr. Kratzman, anything to add?
I want to thank Laurie for the question, because personally, I knew the question was coming, but now that I'm hearing it, I say, gee, my life and my career hasn't been that bad. I started off in pre-meds trying to follow both my parents who were physicians, and I realized that wasn't for me, and I went into sociology. So I ended up with both a physical science and a social science background, which I really love to use today. When I was in high school, I hated history, and when I became a sociologist, I fell in love with history, because I was able to understand why things happened and how people interacted. So I think that's a very important aspect of anyone's career. And I think the way to answer the question, my daughter went to Bates College, and she did not graduate with a degree, but 4 concentrations. And I think today, with a liberal arts education, you should really take advantage of what's there and have that concentration. For today, based on my background, software, AI, computers are going to be essential, but most kids are more literate about a computer than I could ever hope to be. I think sociology, data, and understanding social determinants of health, math, languages, philosophy, and logic are all important there if you want to get into the business world to understand how to structure things. And I think we have to go back and spend more time research. And I hated being in the labs for 4 years, but I really miss being in the labs. Maybe I need psychiatric help. But anyway, I think great question. I think let your heart drive you, and let your brain just open up, and don't get yourself pigeonholed in any one space until you know you're ready to do it.
I think that's good advice. I think Tara will appreciate that. Thank you so much.
We also have a question from one of our faculty members, so let's have Trevor St. Clair join us.
I'm Dr. Trevor St. Clair, Assistant Professor in the Master of Occupational Therapy program at Cabarrus College. Which of these technologies discussed today are likely to have the biggest impact on educating future healthcare professionals?
So we'd love to hear from any of you. Mr. Edgeton, I think we haven't given you quite as much opportunity to speak today.
Well, I don't know if there's any one particular technology that's going to be, I think they are linked. All of this is linked together. So there is the AI element of this, but AI has a long way to go before it becomes the most impactful thing in healthcare. I think this also when I look at this, as the consumer of healthcare becomes more knowledgeable and more empowered to own their own record and their own information, and to manage their health more effectively in a partnership with their healthcare providers and their systems, it may not be always the traditional system. In fact, you will probably have more virtual healthcare, as we have learned in the pandemic, many more many more interactions with healthcare delivery people, maybe not in your own state. Could be, you can get expert consultation in a virtual meeting. Nothing will ever replace the hands-on, but you can certainly get early stage first looks online. So I'm not sure there's just one. I think there's going to be many, and I think that we still have a lot to learn about interoperability. That is going to be a key, because all this stuff is colliding. All these data points are colliding. Those are just some thoughts I have.
So I'll open it up. Dr. Shrestha, Val, which one of you wants to jump in next?
Rasu, go ahead. I don't know if I have an answer yet.
It's a great question, right? Biggest impact, and so I would agree. I think, all of these technologies, capabilities that we talked about could have a lot of impact. I think when it comes to education of future healthcare professionals, one of the areas that I'm really gung-ho about is in our advancements in the simulation realm. When you talk about not just artificial intelligence, but also augmented reality, virtual reality, mixed reality, the simulation elements are really, really exciting. I'm also parlaying that against some of what we're planning for the Innovation District and sort of the medical school that we're building out here. We're really talking about building out a truly world-class experiential simulation innovation center here, and part of what we're going to be doing is leveraging these technologies and capabilities to teach the specifics of how we're going to use these robotic devices, but also telementoring, also simulation and care team training, because that's, I think, really, really important as well. So the entire realm of simulation, I think, is very exciting. On the ground, though, I think the point that was raised earlier about interoperability and some of the challenges of interoperability, I think there are opportunities there for us to have more impact, as it relates to the future of healthcare as well. I was talking to the ONC, the Office of the National Coordinator, a couple of weeks ago, and one of the comments that I made was, when you think about the last 20, 30 years in our journey of embracing electronic health records, it's almost been a crawl, walk, run sort of an approach, right? So initially, the first decade was more of a crawl, and every vendor like Epic or Cerner or any startup company with an electronic health record system had their own proprietary standards. And it was a crawl because those standards didn't talk to each other, and that was the business model. Was these companies set up their own standards so that they'd be able to sell more of their widgets and their devices. Then in the following decade, so this decade past, there was more of a walk, and with interoperability standards becoming more of the play, with the HHS, the Health and Human Services, and the ONC. Incentivizing more of the data exchange components, I think interoperability became more real. The opportunity in the next decade is really for us to run. So the crawl, walk, run analogy is true, because now we can really embrace a lot of the APIs, the application programming interfaces, the specifics of standards such as HL7 FHIR, again for the informaticians and those in the IT realm. These are capabilities that really enhance the level of data exchange between the devices that we're talking about today, or the electronic health systems that we're struggling with at the back end. So lots and lots of opportunities around that.
Mr. Kratzman, anything to add?
I think I'm going to be somewhat provocative. I don't think it's the right question. I don't think it's an issue of technology. I think it's an issue of how we use our mind to allow us to see what we can do with the technology and what the patients and the doctors need. I think it's going to be some kind of integrated network in the future where we basically understand the inside of the body and the outside of the body and how it has to come together to work. Same way that you kind of build a company. So I think everything we've talked about is important, but my nephew just graduated from medical school 3 years ago, and now he's an ED doc. And I have these conversations with him, and I said, I want to see the humanitarianism. You can answer the questions, you can know to use the tools, but I mean, how are you going to make that work well for your patients and for your fellow colleagues? So I want to maybe change the question, but I think everything is important, but I think more importantly is how we approach the education of the future doctors also.
So that brings us to the, I guess, conclusion of our prepared questions, but we have opened up the Q&A for our audience. And as you all have been speaking this afternoon, we've already received several questions. So I'll try to weed through them sort of as they've come in, but try to start with the big picture questions and maybe get into some specifics. Mr. Edgeton, do you have a comment?
I do. I wanted to add something just relative to that last question. Just it might be of interest to your audience. On September 23rd and 24th, there'll be the inaugural Virtual Healthcare Innovation Conference. It will be held, the Biotech Center is putting that on with UNC Fast Tracks and 8 other of the large healthcare systems in the state. And it's really a pioneering event that is intended to provide foundational innovation education to frontline clinicians such as physicians, nurses, PAs, and allied health professionals. And it will also provide an opportunity for collaboration among the big health systems. So wanted to let you know that, and that might help answer some of the question about how do we handle this in the future and training people and getting them ready. So
absolutely, that's very helpful. Thank you for sharing that. So one of the things that has been referenced by each of you as we've gone through the afternoon has been the efficiencies and cost savings that some of these technologies will bring about. And so there's been a couple questions that I'm kind of merging together here in terms of, despite the cost savings, it still sounds expensive. So will the savings be truly outweighed by the cost of the technology? And what, if any, impact could this potentially have on health insurance? So any thoughts on the cost benefits of this approach?
I'll stick my foot in my mouth first, and Rasu and Doug can correct me. I think if we take a look at what we call the quadruple aim, which is up in front of all of us, which is basically how do we improve the quality of care on the population? How do we improve the patient satisfaction? How do we, now that I'm going to talk about it, reduce the cost of care and then reduce provider burnout? Yeah. I think that the concept of efficiency and cost of savings is both direct and indirect, and we have to look at it from a holistic point of view. I don't think we can. The insurance companies will argue one way, and I think the doctors and the providers in the hospitals can argue another way. But I think the reality is, as Tom Hearn would say, we're both recovering hospital administrators. I think that we have to approach this very, very differently, and that we have to stop practicing defensive medicine. We have to use the tools better, and we have to be able to deliver the right cost, the right care at the right time. We need to spend more than 11 minutes with our patients on an annual basis. So I don't know whether I answered it correctly, but I think the reality is that the technology will allow efficiency, will allow us to be smarter, will allow us to deliver the care better, and hopefully that will bring down the cost. But as long as things like hospital charge masters exist and the insurance companies want to play with reimbursement, that's a challenge that maybe we can't necessarily address on what we talked about today.
That's a really good point. When you think about cost, quality, access, and experience as well, and you parlay that against all of the different technologies and advancements that we're talking about today, I think fundamentally, so I would agree with Val. We need to really think differently in terms of how it is that we're managing the entire economics of healthcare, even, right? Because there's a lot of overhead in healthcare, and even just you don't have to look far. Just even in the last year plus of us living through the pandemic, a lot of health systems are really suffering as a result of what's happened, right? We've made tremendous losses, millions of dollars of worth of losses in the last year. But also at the same time, when you look at the payers, they've had bumper quarters, right from the first quarter of the previous year, and it's amazing because these payers are really actually benefiting from what we're seeing out there, not just because of the pandemic, yes, because of the pandemic, but also because the economics, I think, are actually not balanced well. So there's a lot of overhead overall in the way that healthcare economics works. And the United States in particular, right? There's a reason why it's a $3.8 trillion industry with a lot of the bloating at the back. And I think part of the solution here really is for us to have more of a patient first or a consumer first approach, where we're empowering our patients and giving them access to their data, empowering them with choice, making sure that we're able to overall bring the cost of care down as a result of the competitive dynamics that choice naturally spurs, but also at the same time garnering those efficiencies so that we're really able to up that experience. So whether it's providers that are really trying to take on more risk and maybe even working more creatively with payers, and payers that are now coming into the provider space that are trying to really go into that digital front door element of patient care. I think there's a lot to be said about thinking creatively and thinking differently in terms of how these cost models need to continue to evolve so that we can overall bring the cost of care down.
I'll add sort of my favorite one in there. This is not controversial, but it's surprising how many people don't know that you spend about, I've forgotten, it's a huge percentage, like greater than 60% of your entire dollars you spend on healthcare in your life in the last trimester of your life. So somehow or another, that seems like a prime spot for us to look as a country and as a society at what we can do to better use data to manage that, but to also understand there are some ethics and things at end of life that we really need to get our culture around. Because when you think about cost of healthcare and you look at the big ticket items, end stage renal disease. Well, some of the work being done at some of our regenerative medicine labs might have an answer for that at some point in time. If they keep pushing that forward, then that will have an impact on the payer side. And so all of these are kind of tied together, and there is the ethics piece in there that ties us together. So anyway, I find it, tackling it from the most expensive things backwards seems to be a more effective approach, but that's just a reformed hospital administrator speaking. So
yeah. We talked about preventative medicine in 1973 with the passing of the Health Maintenance Act.
Right.
And we created gatekeepers. We didn't create prevention. But today, as Rasu said, we are moving to prevention. And as Doug said, if we're spending that 60% in the last trimester, maybe prevention is what we really need to be practicing more of, and people taking better care of themselves. And maybe that's the starting process. Again, it could be a sociological change versus a systematic change within healthcare.
Very interesting. As I review the other questions there, we obviously covered a lot of different types of technologies today, and there were some additional questions about areas that you all didn't touch on. So I'll just share them with you, and if you have any additional insight, I think you can jump in as you're interested. So there were questions pertaining to advancement in biotechnology around artificial kidneys and hearts, things related to orthotics and prosthetics, as well as the broad use of robotics. So if any of those are near and dear to your heart, or you have something very exciting to share, please take this opportunity to do so.
I'll start a little bit. Having been fortunate to be involved in some of the early stages of tissue engineering and regenerative medicine with the work I did at Wake Forest with Dr. Atala and his team, the promise is there for a lot of really important things. One of the first things we were able to commercialize or to move to the market had to do with vision. Vision is very important, and there's a couple of cells that they could regenerate that would help 10,000 people a year. So one of the things I think a lot of technology is going to end up focusing on is small numbers of people, and that becomes expensive when you start trying to scale. But that when you have a rare disease, which is what we're seeing a lot of our genomic work going into, is rare diseases. Rare diseases means under 100,000 people. So, you know, all of a sudden you're thinking, gosh, there's a small number of people here that need this, and it will totally change their life, like being able to see. That is important. And so I think there is a lot of opportunity for regenerative medicine, for orthotics, custom-made, prosthetics, things that are going to have more, and you're starting to hear it with neuroscience, connectivity to brain and brain activity to give you control over artificial hand and joints. So there will be a lot of opportunities in the future. All of that requires math, science, engineering, and really a good patient interactive skills. So those are a few thoughts I have.
Yeah, that's wonderful. Just to add to that, when you think about the progress that's being made in regenerative medicine, it's just amazing, right? We're 3D printing kidneys today. We're 3D printing, body parts and transplanting these back into human beings. And if you think about, the main problem with, organ transplantation today, it's organ rejection, right? It's the immune system basically saying, nope, not having that. And there's an immediate rejection, even with the immunosuppressants that you bolus dose these patients with. But when you're essentially taking that patient's own tissue and regenerating it outside in the lab and 3D printing it in the frame of a functioning organ and transplanting it back into that patient, I mean, it's just absolutely amazing. I think in addition to all of the amazing work that's happening around that with Tony Atala and others too, the world of 3D printing is really making a lot of advancements. The VA, for example, is really leading the charge in a lot of the implants and the for example, 3D printed limbs that are actually being implanted on veterans, and it's just amazing how much more functional they are, right? So they're not just there as a prosthetic device. It's actually bringing in functionality. When I was in Pittsburgh at UPMC, we're doing a lot of work to really even bring sense into hands that were artificially placed into veterans who had lost their limbs. There was a robotic demonstration. I remember this is quite some time ago, but when President Obama came to visit one of the centers that we had back in Pittsburgh, this is the first of its kind where we'd actually put this robotic arm in this patient, and the patient, by controlling it with his mind, was able to give the president a fist bump, and he could feel it. And it was just absolutely amazing. So, it's come a long way, and I'm really excited about where it can continue to go, even in the next decade.
Very good. So again, I'm going to kind of merge together a couple questions here, because in the conversation today, we've talked, you all have talked about how this is looking at kind of a redesign of care that will be provided to patients. And so I think of what your comments on how do we ensure that, you know, if we're looking at a virtual care setting where you may have a staff member remote and then someone on site, that they're appropriately prepared and trained to operate in a very different kind of world than they may be operating when they're all together in the same place. And how do we see the roles of some of our current practitioners evolving or potentially expanding, like the nurses in the application of population health concepts?
My observation is that nurses, physician assistants, even docs, everyone is changing on a daily basis. There's no way around it. You have to grow and change every day. It's the same way as an executive or someone working in a company. I had the benefit of spending a couple of days at Thomas Jefferson looking at their virtual triage program for emergency patients. And they had doctors monitoring one station where on one computer was the electronic medical record, the other was the video with the patient, and then the patient was in the room with a nurse in the emergency department in one of the 14 hospitals. And I think what stood out was the natural flow of the communication. It wasn't forced. It was as if it was real, and they were there face to face. And I think the patient appreciated the attention and the detail that was coming up in the recommendation, and the fact that he or she didn't have to basically travel from one side of town to another side of town. So I think that's one aspect of it. And then going back to earlier about 3D. 3D is not new, but it's been around, but I think we're learning how to use it better, and I think that's what's really more important. And when we start integrating the 3D with the robotics and everything else, I think that's the breakthrough.
It's a great question. I'd add a slightly different perspective as well. So I think there are evolving roles as a result of everything that we're talking about today. Care extenders, care navigators. I mean, the big notion right now is really around collaborative care, right? So when you talk about team-based care and training around team-based care, it is around collaborative care, and this is part of what's driving some of these value-based models out there as well. There's a model out there called a patient-centered medical home, and it's nurse practitioners working collaboratively with dietitians and with endocrinologists and primary care physicians and others, all centered around the specifics of the improved outcomes for that patient that's in the center of that collaborative. And I think these types of models, care models, will really continue to take off. The other view that I'll add to this is, continue to be creative in terms of, what's your passion in how you want to bring that passion out in the pursuit of the things that you really want to accomplish, right? So you may start off as a nurse or a PA, but you may end up as an administrator, and I think it's absolutely all right. I think, in fact, we actually need a lot more healthcare professionals, trained in the clinical sciences and such in healthcare administration as well. So roles will continue to evolve. I mean, with the onslaught of entrepreneurship and outside-in dollars to the tune of what we talked about earlier on in our conversation this afternoon, there isn't a lack of roles for those that are really passionate about and knowledgeable about the complexities of healthcare. So keep an open mind when you're thinking about your career trajectory, because it might take turns that you're perhaps not anticipated in your earlier part of your career journey.
I also think that there's opportunities out there as people are looking at their careers in the big picture things. There's a lot of need at the state level for people who understand the local healthcare delivery issues, and at the federal level too. I would say a lot of the people I have met and encountered started off as either a PA or a nurse and decided to move up and got additional training and moved into more of the government related positions that we encounter a lot too.
So I have one last question, Dr. Shrestha, I'm glad that you were talking about the evolution of the roles as well as the outcomes we see with patients as a result of this patient-centered and very collaborative care. But I want to take it from the perspective of the patient themselves. And as many people probably had to do in the last year, they probably had a virtual care visit at some point or another. And just in talking with folks, some people respond very positively to that because they see the time it saved and the convenience of it, where others felt that it was somewhat of a disconnect from the personal conversation they might normally have with the doctor. So as these roles evolve, how do we ensure that the patients are prepared to evolve with us, and so that they see the benefit that this redesign can potentially have for them?
So I'll take a stab at it, but please, others feel free to chime in as well. I think it is important to acknowledge the facts. We're thinking about change, and as we're enabling this transformation that we're talking about today, it is important to acknowledge the fact that, you know, you have patients or consumers, people that are in different parts of that journey, even in embracing technology, or different stratas of the socioeconomic, realities of everyday life out there. So I think it's important for us to meet our patients where they choose to meet us, right? Whether it's their economic status, or whether it's their zip code that they live in, or the specifics of their embrace of technology or not. It's important for us to meet them where they choose to meet us. But also at the same time, I think it's also important for us in healthcare to really widen our aperture and say, look, what we've been doing thus far is really focusing in on one element of what I call the consumer journey, the transformative consumer journey. And that element really is around care. And I think, you know, it really starts at the beginning in terms of awareness, because, you know, people are curious, right? They might have a certain symptom, or they might, you know, have a dinner conversation with their loved one, even if it's a virtual conversation with how we're seeing things pan out in the last year. But awareness, you know, Google searches, right? They're looking up symptoms. They're coming to us in healthcare a lot more informed than they've ever been in the past. So I think that's really important. So awareness, consideration, selection, and then care. Obviously, care is important as well. And then advocacy, right? They're advocating for themselves, for their loved ones, and they're saying, hey, you should go out and get this vaccination because I think it's important. You know, you should go out and wear masks, or you should, you know, go out and get your colonoscopy. You're now 50, you know. So advocacy is really important. So I think broadening that aperture and really focusing in on that transformative consumer experience, and then meeting them where they choose to meet us, and educating them, right? Making sure that we're able to speak to them at the language that that is translatable to again the patients and the communities that we're speaking to. I think that's really important as well.
I will add, I think, looking to the future a little bit there. Some of the things that you look at the national health statistics and you see what's coming down the pipeline, and the things that they're saying are going to squash our federal budget are related to Alzheimer's, Parkinson's, and some of these catastrophic type diseases. So there are going to be many opportunities in there for people to help solve those bigger problems. And that will be everything from actually the science side of what causes it and how do we treat it and how do we get better, to how do you take care of and manage those patients, because there's a prediction that about half the people over the age of 65 will have some kind of diminished capacity due to those diseases, and the other half will end up having to take care of them. So of the other half, the people over 65 will end up taking care of them. So there's going to be a lot of opportunities out there, and there are plenty of people who will find this as their passion to help solve these big problems. So, and when you put it in terms of federal dollars, it will make the federal expenditure for defense look small when you get that much population. So just something to think about.
And I guess I'll be provocative once again, and I think maybe we need to add to what we define as healthcare, taking into consideration that we have caregivers out there who are giving up careers to take care of people, and no one's really taking care of the caregivers. I've spent a lot of time with Charlotte Yeh and people at AARP and United Healthcare having this conversation. So maybe as we move forward, there has to be a better balance from the payer side of the equation with respect to what is reimbursable and to whom and for what. Because if someone's taking care of someone and they're giving up half their life or 2/3 of their life or all of their life, there has to be some kind of remuneration as well as emotional support as well as other support for that individual. And that's a huge part of the future of healthcare.
Well said, well said. We are coming up to the top of the hour very shortly. Dr. Shrestha, Mr. Kratzman, and Mr. Edgeton, thank you for your expertise and all the enlightening information you've shared today. Throughout the afternoon, you reminded us that as wonderful as the technology itself may be, we must always keep our eyes on how can we effectively deliver quality, affordable, collaborative care that empowers patients to be knowledgeable partners in managing health outcomes. And you've also reminded us of the importance of thinking creatively and differently to envision what we can do with technology as we pivot to that increasing emphasis on population health and wellness. So you've really piqued our interest. I am absolutely certain there are going to be many conversations which are going to follow in our classrooms and workplace. So thank you to each of you. Thank you to all of you who have joined us today. And on behalf of Cabarrus College of Health Sciences and Carolinas College of Health Sciences, we wish all of you a good evening. Thank you.
Thank you.
Goodbye.
Thank you very much. Yep.
Good evening.